All right. Okay, well, thanks so much for talking to us today, Lana, about your research. So Lana is a clinical neuropsychologist and research fellow in the Department of Neuroscience at Monash University. And her research involves the development of interventions and exploration of treatments to reduce functional seizure symptoms and improve health-related quality of life and identify predictors for successful treatment outcomes. So I'm going to let Lana
listen to a Zoom.
So can everyone please have their microphones on mute before we start, and then we'll have questions at the end. You're welcome to put questions in the chat as we're going, and we'll do them at the end. But we can all be on mute except our presenter. All right, over to you, Lana. Thank you.
Thanks very much, Kate. And thanks for inviting me here today to talk about our functional seizures research with your audience as part of FND Awareness Day, which is a good opportunity, I think, for a lot of people who don't know about functional seizures to learn more about them. So this is me, and I treat functional seizures. And for those of you who don't know what functional seizures are, they're involuntary episodes that resemble epilepsy. They're a type of functional neurological disorder, and they look like epileptic seizures, but unlike epilepsy, there's no electrical storm in the brain, and they're characterized by sudden involuntary symptoms, and they can include things like shaking, speech difficulties, unresponsiveness and spasms and jerks and collapses, which can be extremely debilitating and very distressing. And the condition we know disproportionately affects women, and it's most prevalent in 15 to 19-year-olds. So unfortunately, patients with functional seizures tend to fall between the cracks of neurology and psychiatry, with neurologists doing the diagnosis and psychologists and psychiatrists doing the treatment. So to address this gap, the Alfred Hospital's Functional Seizures Clinic was established in 2019. And the clinic is led by Dr. Toby Winton-Brown, and it's a multidisciplinary clinic, which is the first and only one of its kind in Australia. And what we do is integrate psychiatry and neuropsychology with neurology, and we all work together, which means that we can share perspectives, and that helps us to understand our patients a lot better. And shortly after establishing the clinic, we began thinking about developing a brief therapy program. Given the significant barriers to care experienced by people with functional seizures, or FS, as we call them, including an inability to drive because of their seizures, financial constraints, and a lack of accessible treatment, we started to develop a brief telehealth intervention for people with FS. And we talked with patients initially, during and after their sessions with us, and we asked them what they found helpful and what wasn't helpful, and then we incorporated their suggestions and feedback into the therapy as we were building it initially. And we aimed to create a therapy that primarily targets functional symptoms rather than focus on other conditions that commonly occur with functional seizures, such as anxiety and depression. And we also wanted to create a therapy that we could continue to update as more evidence became available. And we incorporated the latest research regarding processes that were thought to underlie functional seizures. Importantly, also, we wanted it to be agnostic. And what I mean by that is that rather than, a clinician telling the patient why they think the seizures may have developed, we wanted to remain very curious and open, and to travel with the patient on their journey to discover or uncover their own functional seizure story over time. Because often it's not immediately obvious what's triggering the episodes, and it's usually multifactorial, meaning there's lots of pieces of the functional seizure puzzle to put together. So it's our job and the job of our colleagues to help every person discover that for themselves. So I like to think of it as a bit like a jigsaw puzzle. So, some people like to start when they're building a jigsaw, just doing all the edge pieces on the periphery. Other people like to do the background pieces first. They find all the, plain colored pieces or something like that. Other people try and find the most detailed pieces, so they'll go sort of right to the crux of it straight away. Other people just find the easy pieces. And then there's some people that are extremely methodical and they just like to work left to right or bottom to top. So it's very much like therapy where, you know, we can guide people with clues and encouragement, but they're ultimately the ones who hold the pieces and who can put their unique individual experiences or personal seizure-related factors together. But they do need to have that agency and control of freedom to do so in their own way and in their own time. So we noticed when we initially started working with people with functional seizures that they had really interesting and diverse ways of thinking about their seizures. And there seemed to be some common themes that we noticed. So we designed a set of questions that would form an introductory session before starting therapy to help us get to know the person better, to understand what they knew and understood about FS, and to learn from them in terms of how they were making sense of what was happening both before and since FS arrived in their lives. And we really wanted to understand how FS impacted their lives, including their day-to-day functioning, as well as their relationships and the people around them. And we found that asking people, what do you think your functional seizure symptoms are telling you, helped us and helped our patients to think about mind-body unity and what might be subconsciously driving the episodes. It's often helpful to think about functional seizures as something separate from the self rather than being part of the self. And sometimes, particularly for people who have had the condition for a very long time, the seizures, sometimes, not always, but can or have become a key part of their identity. And some patients have told us that they actually can't imagine living without the seizures. And it's actually quite scary for them to think about that happening. So being able to talk about the seizures as serving a role in some way, like having a protective function, for example, we found can be very useful. And we put this question to 99 people with functional seizures and published our findings. And we did find that common themes emerged. So we found that the predominant theme was this theme of what we call an we found that the predominant theme was that of an enforced hiatus. So where people felt that their seizure was somehow making them sort of stop or slow down or relax. And then there were two other themes that emerged. One was personal growth, that one in the middle there in the green, where the seizure seemed to be, they interpreted their seizure as helping them in some way. So that person said, you know, their seizure was saying, get help and get your life together. And then there was a third theme that kept coming up, and that was contempt, where the seizure was actually sort of talking to them in a way that was quite punishing, you know, quite punitive. It was punishing them or admonishing them for something. So there were amazingly thoughtful and insightful patient reflections, which are all in the paper, where we also discuss how the responses reflect various models that have been proposed of FS. And in the introductory session, we also ask people what they would miss about not having the seizures anymore, and whether they would push a magic button that could get rid of the seizures forever. And some of you might be surprised to learn that not everybody says that they would actually push the button that would get rid of their seizures, which is super interesting. So on to the actual therapy itself. So in terms of the next 5 sessions after that introductory session, we start by targeting the nervous system using bottom-up approaches rather than top-down cognitive work. And that means that rather than starting to talk about emotions or thoughts and feelings, we use lifestyle factors, things like physical activity, exercise, movement, nutrition, sleep, and social connection as modifiable targets for reducing FS due to their influence on the brain and the body. And we then give people practical tools that they can experiment with and practice to begin learning how they might be able to manage a seizure. And we're really aiming to get people more in tune with their body. So because of things like dissociation, which is a bodily response that can cause people to feel disconnected from themselves, or poor interoception, which is just a very long word, which means that it's difficult to notice and or to interpret the physical cues coming from inside the body. So things like changes in heart rate or breathing rate, And so for those two reasons and for others, people's seizures can really seem to come out of the blue, which really makes it quite challenging for them to learn to intervene or to catch the seizure before it actually takes hold. And if we think about it, like it's a bit like learning to catch the ball. So when you see young children trying to catch, when they're very first learning to catch a ball, they seem really surprised when the ball arrives. And it's really common for them to turn away from the ball or close their eyes as they anticipate its arrival. But with practice, our brains get better and better at learning the adjustments needed to enhance prediction. So there's really smooth and fine adjustments that we are learning every time we attempt it. And then eventually we catch the ball, which is lovely. And we stop the ball by catching it rather than it flying past us or hitting us in the face. And it's actually really exciting when we start for the first time with a seizure too. So I think the saying, keep your eyes on the ball, is a good one. And it's a way of telling us to pay attention to something. And with FS, what we want to try and get better at is noticing and understanding and responding in a different way that we may have been habitually in the past to these internal cues coming from our body, so that then the brain can sort of learn to predict them better over time. Okay, so let's see what's next. Details about, why we included all those treatment components and why we put them in that particular sequence and order are published in this paper here in Epilepsia. I think it's, when discussing treatment elements with patients, we're always linking it to brain function, because given that functional seizures are associated, they're a temporary dysfunctional brain network miscommunication, it's really important that people understand why we're suggesting what we're suggesting. Like, we haven't sort of just pulled it out of a hat. Like, we're suggesting movement or exercise or improving sleep or breathing in a certain way, but it's all evidence-based. And I think that's much more helpful than someone just saying, oh, just breathe, or, just do yoga or something. I think it motivates people to make changes in their lives that are not only going to benefit them in terms of their seizures, but also in terms of their day-to-day functioning and their overall health in general. And the paper also includes results from the first 29 patients. So the really first patients who were engaged in reprogram for the very first time in the clinic. And that was when we were sort of just trying it out. And we found that it was feasible and acceptable to patients. And most of them reported a reduction in their seizures. And they also reported other benefits, including quality of life and improved functioning. So the dark blue and the blue there are people who reported better and much better on those things on the left. The green was no change, the orange was worse, and the red was much worse. So you can see overwhelmingly people are doing pretty well. And we got some really encouraging feedback from patients and their families. It was overwhelmingly positive. And so then we thought, well, how about we develop a self-guided internet version of Reprogram and give that a go, which to our knowledge is the first structured self-guided brief internet therapy course for FS. We were really interested to see whether people with FS would be interested in this. Would they or could they undertake an intervention on their own with little to no guidance from anybody, and whether it would be, helpful to them. So that's when we developed the trial, and we designed a randomized controlled trial to test both versions of Reprogram to compare them to each other and to standard care. A randomized controlled trial, known as an RCT, it's the gold standard method for measuring the effectiveness of new treatments or therapies. And there are very, very few RCTs in functional seizure research. So our RCT has been running for several years, and it's actually wrapping up this week. And we recruited 107 participants, which is the second largest FS randomized controlled trial in the world. And we're just super grateful to everybody who took part. The baseline results are published in Epilepsy and Behaviour, and I'm just only going to share a few of those findings with the audience tonight. So just in terms of comorbidities, as expected and as we've seen in other studies, commonly people also had anxiety, depression, and post-traumatic stress disorder, which is consistent with other studies. And people also had migraine and chronic pain. They were quite common co-occurring neurological conditions. In terms of previous psychological input, most people had seen a psychologist or a counsellor before coming into the study. The little boxes down there on the left are over how many years somebody had any sort of engagement with a psychologist or a counsellor. So you can see that the green there, the majority of those people reporting 3 or more years of psychological input who had some input at some point across their lifetime. And in terms of work, most people were unemployed and they weren't receiving any kind of government disability support payment. And I just wanted to share something reassuring, I guess, from the findings that we gave everybody neuropsychological testing at baseline, where we looked at people's attention, processing speed, executive function. Executive function is a set of mental skills, including things like working memory, flexible thinking, and self-control. And reassuringly, at a group level, our RCT cohort had normal neurocognitive function. And we then evaluated these results further using 2 different methods established by the International Classification of Cognitive Disorders in Epilepsy Initiative, which is a mouthful. But basically, no matter which way we looked at it, using this method here, this first method, or the second method, no participants had what we call an isolated or a bi-domain impairment in executive function, which is super interesting. And then we thought, okay, well, let's see if any of these factors on the left are associated with cognitive function. And so what we found that none of these things on the left, which was very surprising, were related to cognitive function. So, you know, what type of seizure someone had, how long they'd had their seizures, whether they had migraine or chronic pain or a family history of dementia, how many medications they were on. None of those things were related to their cognitive function. So that was a really interesting finding for us. And now in terms of seizures themselves, this graph here shows the change in monthly seizure frequency between T0. If you look down there on the x-axis on the left, T0, that's our baseline. So that's before people were randomly allocated to one of the study arms. And T1 on the right there, which was the first very early follow-up time point. That was our first time point. It was immediately about 6 weeks or so after treatment. So the blue line is the self-guided internet version of Reprogram. The red line is the therapist-led version of Reprogram. And the green line is standard care. So we can see that at short-term follow-up, the self-guided internet version of Reprogram demonstrated significantly better seizure reduction compared to standard care in the clinic. So in the self-guided arm, on average, people's monthly seizure frequency had almost halved at this early time point. And we also had some secondary measures. So there were other things we were looking at to see whether any of the treatments had an effect on them. And we were very pleased to see that the self-guided internet version of Reprogram also showed significant reductions in anxiety and depression compared to standard care in the clinic. So again, that blue line is the self-guided Reprogram, the red line is the guided Reprogram, and the green line is standard care. So our exploratory analyses actually showed something a little bit more fine-grained in that if someone had a diagnosis of anxiety and chronic pain, anxiety and chronic pain were moderators of how effective the treatment was, meaning that the self-guided Reprogram was actually more effective in reducing seizures if someone had anxiety or chronic pain. So in terms of, you know, do people actually stick with the therapy? You know, do they drop out? Regarding adherence, there was 100% adherence rate in the therapist-guided reprogram, which was the same as what we had seen in our early clinic evaluation of those first 29 patients who went through. Everyone who actually enrolled in the program completed all of the sessions. This one's for the self-guided reprogram, so this was a little bit different. So everyone completed the first 2 sessions, and then 94% completed 3 sessions, 61% 4 sessions, and just under half completed all the 5 sessions, which is in line with the findings of internet intervention studies more broadly. And we also administered the client satisfaction questionnaire, and we found no difference in the treatment satisfaction between the different versions of reprogram. So whether people did the self-guided or the guided version, they were equally as satisfied. And then we had another questionnaire, the IEUQ, to evaluate the internet intervention. And most people reported a positive experience with and perception of the internet version, which is looking like it may be a promising kind of therapy for FS, as well as helping to reduce anxiety and depression. Certainly it's accessible, it would be low cost, and it's potentially scalable, meaning that it could be an evidence-based treatment that we could use to reach a lot of people. It's really important to keep in mind that we only have, this is all the short-term results. So we don't know whether these results will hold up over the long term. We followed everybody in the study for 12 months. And as I mentioned, the trial is finishing this week. So we're going to be starting to analyze those results very soon. But I think regardless, to my mind, the internet program has a lot of value because it could be used, for example, say you're a newly diagnosed patient, somebody tells you you have a diagnosis of functional seizures, then you could immediately start this brief internet 6-week program while you're waiting to get into some kind of therapy or waiting to be seen by somebody else. So I think that, you know, we don't know what the long-term results are going to be, but nevertheless, I think that it might find its place somewhere in functional seizures treatment. So there's so much that we still have to do though. So we need to do a lot of work to explore why reprogram works for some people, who it works best for, who it doesn't work for, and of course, how we can keep making it better. So we understand that, you know, it's not always possible for people to fully engage in a program for various reasons. For example, someone might be in a crisis, or they could be, you know, currently experiencing a high level of trauma. They might have other serious medical conditions, or they might be struggling with, you know, severe depression, which, you know, as we know, makes it difficult to engage with anything much at all. So we need to keep working on longer term options as well for those people whose seizures don't reduce, and who would benefit from a longer term therapy, and who need treatment for other things as well. In our experience, the people whose seizures do go into remission or who fully recover are those who are able to fully engage with the program, to make a lot of changes, experiment with seizure management tools and strategies, to undertake the homework and activities to improve body awareness. And, you know, it's really hard. I mean, you know, if you think of anything that's almost like something that you've been doing for a while, and someone's asking you to change those things, you know, we all struggle to develop new habits, and it takes a lot of effort. So we really appreciate that. And I guess finally, just to say that importantly, I think we really do need to be working together. So, you know, clinicians and patients, rather than an us and them think. I think we're on the same side of the table. We're looking at everything together. We need to develop shared goals to really improve our understanding about this condition, and to develop more targeted treatments. We're currently organising a lived experience consultation on our clinic service model to learn whether what we're doing is helpful and how we can change things and make things better. And part of that is the establishment of a Functional Seizures Consumer Advisory Committee. So I think that's pretty exciting news, and it would be great. So before questions, I just want to thank all these wonderful people for making the research possible. Research is a big undertaking. It takes, you know, a lot of effort, time, and I'd like to thank Dr. Toby Minton-Brown, Terry O'Brien, Genevieve Rayner, Rubina Alpizis, and also our very generous clinicians who all volunteered to work with us on the reprogrammed trial. So we're very grateful to all of them. Otherwise, we wouldn't have been able to do that at all. And that's just a list of references for anyone who might want to delve into those papers and have a further read. But yeah, now I think we should open for questions, I guess.
That's wonderful. Thanks so much, Lana. That's great work. And I've noticed a lot of those references are open access, so people can download them from the net without having to access university databases.
Yeah.
The self-guided option sounds like a wonderful tool. Are you envisioning that being available to the public, so people who are diagnosed, sort of anyone could access it in the future?
Yeah, we're really hoping to. So we've had a lot of interest internationally as well. So what our next step is we're trying to apply for some sort of funding to make that a possibility to run a larger scale trial, both here, but also to see, you know, cross-culturally, whether that's something that people, for sure. Yeah.
Yeah, but someone has said, you know, can they get hold of this self-guided program? So it would be available also to people across the country. So you wouldn't have to be local to Monash or Alfred.
Yeah, that's the idea. So what we're doing at the moment is we have been working, you know, we're only just wrapping up the trial. So we've been going through all of the responses from people who did the self-guided version, just like we did the first time when we sort of piloted it in the clinic. And we're going to try and, you know, obviously take on board all of the suggestions and make it even better if we can.
Yeah.
And then we definitely will be working out how to make it accessible to people, and then, you know, more people who try it, more people give us feedback, we can keep
refining it. Yeah, awesome. And when you did the follow-up, T0 and T1, the follow-up that you did where you showed the reduction in seizures, was that at the end of the 5-6 weeks?
Yeah, actually, it was meant to be 6 weeks because it's very hard to get hold of people. It turned out to be, I think, between 6 and 12 weeks, which is kind of good in itself. So it means that, you know, those results were holding up quite well. And then we did check in with people. We did T2, 3, 4. So we saw them again at 3 months, 6 months, and 12 months. So we've followed them right the way through, and the analysis we'll be doing is, you know, going to be quite complicated and complex, and our statistician will be doing all of that. But, you know, we'll be able to see, track how people go, because it is a really fluctuating condition as well, as we know.
And other things can impact on it.
Absolutely.
Yeah, someone's mentioned here, I think it's Sarah, said she was part of the trial, but her seizures have got worse. I think she's interested in more help.
Yeah, so sorry, I don't know. I'm trying to see who.
Sarah's iPad, not sure. We've got lots of people here, so more people than on the screen, but you'll probably be following up with everyone in the 12 months mark.
That's right. Yeah. What's out of interest, which arm of the study were you in, Sarah? She might not be able to.
There's a couple of pages here, so it's hard to find. Sarah, if you wanted to comment, or you can speak up if you want. I can't. Oh, Sarah said she was in the guided one.
Right. Yeah, she was. Yeah. That's right. And I think that's right. We know that we've just actually we've submitted another paper. We were able to show, in line with a couple of other studies in the literature, that about 40% of people at the Alfred, when they get diagnosed with functional seizures, by the time we even see them for our first appointment in clinic, their seizures have spontaneously remitted. And so then there's another set of, you know, people who, after a brief intervention, their seizures get better. And then there are a proportion of people that, and this is what we're now needing to sort of do work on and analyse, who don't get better after a brief intervention. So we need to think about what can we develop further for those. Absolutely. Yeah.
And I certainly see some people who have it for a very long time. Liz has got her hand up. Liz, did you want to jump in? You can unmute yourself if you like.
I think I did. Hi. Yeah, thank you so much. That was wonderful, Lana. I wondered, you'd mentioned that the team at the clinic consists of psychologists and neuropsychologists, or
Yeah, and psychiatrists and neurologists.
Okay, who is it that runs, which discipline runs the guided part of the program? Is it the psychologists?
The psychologists, yeah.
Okay.
Psychologists and neuropsychologists, yeah.
Okay.
Yeah, that's right, yeah. But I mean, I think the advantage of the clinic is we all get to speak to each other. So, you know, we meet and we really sort of, you know, are abreast of all patients. So I think that's what the value in one of these clinics is. We don't have what I'd be great to have a social worker or something like that. I mean, we're a publicly funded clinic, so you know,
it's very tight. My background's in health. I'm a nurse. Would you foresee in the future that there'd be a role for coaching as a you know, as part of the multidisciplinary team, you know, working on mindset change and so forth?
Yeah, that's a really great suggestion, and I think when our we're very, very, very soon to be rolling out, which some people here will get emails very shortly, this lived experience call out for, you know, people who are interested to put their hand up to be part of that lived experience workforce. And I think, you know, my sort of, I guess, dream is that, and this is probably pie in the sky, but, you know, say you develop seizures, you get your diagnosis, but there's someone there that has been through it that can say, look, you know, it's okay. I've been, you know, like they do, like we do.
Yeah, a lot of peer support
like we do have in many other areas. Yeah. So this is what we're trying to do.
Guiding people.
Yeah. Great. Thank you so much.
Belinda, you've got your hand up. Do you want to unmute yourself?
Thanks, Kate. Lana, I was privileged to be in the self-guided group last year and the year before. But what I'd love to know, have many of the other states taken on the information to try and build from your studies in the hope that we can get this permanently in Queensland and other states instead of having to do telehealth?
Yeah, it would be wonderful. Not that I know of. And I think Belinda, the kind of the sticking point is we need funding to do it. So, and we need, it will get there. I think it's just time and it's just, I hear what you're saying though. Yeah. It would be wonderful, wouldn't it? To just be able to give that to people and,
In terms of cost benefit, often with funding, you're looking at, you know, reduction in health service use and hospital admissions, that kind of stuff. Will you be doing some cost benefit analysis with this?
We will. That's a really great question, Kate. We did collect all of that information as part of the trial. We haven't even yet looked at it. And it was with a view to collating all of that so that we could then, you know, have evidence and the need is there.
Yeah, that often is what speaks to government is if we provide this at a certain cost, it will reduce these long-term costs. Jane had a question around, did you look at clients who were autistic or ADHD, and did that have any impact on the outcomes?
Great question. In our study, we have about 10% of that cohort with a diagnosis of autism. We haven't broken it down to look at those people specifically, but we will be, And we didn't look at ADHD specifically. There weren't that many, just from off the top of my head. It'll probably be on that graph, but I don't remember that many people that go back in and have a look. But there's about, I'm just having a look at neurological conditions now. So about around 10%. I don't know if it's lower than other studies, the autism. But you know, there may be higher rates and it's undiagnosed, for example.
Someone's mentioned here around oxygen levels dropping during seizures, and that's something that I've seen with a few clients as well. Someone saying, if your oxygen levels are dropping, is there still a functional seizure? I am definitely seeing clients who are having problems with oxygen levels. during seizures. Is that something that you're seeing as well?
Well, obviously, no. I have to say it's not something that I'm aware of. But we are doing some studies at the moment around cardiorespiratory, I guess, peri-seizure biomarkers. So that's one of my interests, and looking at things like continuous glucose monitoring as well. So all of these sort of biomarkers around time of the seizure to see what might be going on. Yeah, so.
Do you find people having seizures in response to sensory overload? So light, sounds, is that something that you address as part of that intervention?
Yeah, we do, and super common, and yeah, definitely that's a part of the treatment. Yeah.
And then we've got another question here. How were the residential environments for the participants who improved? So I think they're looking at, I don't know, you might not have captured it, around people who might have had a supportive residential environment or an exacerbating environment, and what general environment is needed to support improvement. So I think that's looking at, you know, the sort of environment that person's living with. Are there ongoing stresses at home, sort of thing?
Yeah, that's a fantastic question. We have, and I actually felt sorry for all the participants at Summit. We asked them so many questions, and they were just so gracious around all of this stuff, like who they were living with, how many people were there, you know, all of those things. So we did want to try and capture that. We haven't looked at it, but I've just been part of another study with SEER, who are the home video monitoring unit. Yeah. So that paper will be submitted very shortly, but what we did was look at people having seizures in the home, and what we did was look at the behaviour of others around them and to see whether that did have an effect on the seizure. So that will be coming out hopefully sometime this year. But all of those social factors play a role probably somehow, but we don't quite understand how what the environment is. I don't know that we're quite there yet. There are only 2 studies that have looked at that, but we're the first to look at it in somebody's home environment, naturalistic setting. So I think it's important. Yeah.
Yeah, absolutely. There's some more questions here. Let's see. Someone also asked around sensory processing sensitivity, which is something that we see a lot.
Yeah.
Someone that's asking about the family stresses, so you've mentioned that. Anyone else got questions that they want to jump in? People want to unmute.
What was the question from Rebecca? I didn't quite catch it. When people don't believe you.
Where's that one?
That's
Rebecca,
me.
do you wanna, yeah,
I
go
found
for it.
that my family didn't believe me at all. They thought I was faking because I'm a performance artist. They thought I was a very good actor and that I was doing it for sympathy. And that caused me to become sicker and sicker and sicker. So actually my family were a stressor I had to remove till I could prove to them what was going on.
Yeah, that sounds really difficult and unfortunately very common, and something we are trying to change. I think as part of Reprogram, what we're thinking about doing next is making sort of a reprogram module for family and carers. So that could be like a companion model that you sort of do your part, but at the same time, whoever you want to give it to are sort of understanding what's happening, and you're just providing a lot of more psychoeducation. And also I think on that for junior doctors or healthcare professionals or anyone really who comes into contact with people with the condition, so that we're just really helping to make your world a little bit easier. And that it's terrible that you're already struggling with FS and then you've got to sort of deal with all of that. It's a shame. Yeah,
and unfortunately that does come up in our members. Were you only looking at people 18 years and older, so you weren't dealing with school children?
That's right. That's
It's just frozen.
for children is even better than for adults. So I think the fight.
Hold on, whoever. Sorry, everyone, keep your microphone off, just so we have one person talking at once. Sorry. Go, Lana. I think it's frozen.
The sort of rate of remission shows adults. So that's encouraging.
I'm having a little bit of problem with sound. I'm not sure if other people are as well. So we might wrap up. There's a lot of people who've joined, but Cassie, do you have your hand up? Did you want to say something?
Yeah, I did. Just going back to the oxygen, that was my question. Now, we've just had that with the cyclone stuff just recently. It did happen in the hospital as well, but when we got the doctor, she's like, everything had calmed down. But even the paramedics are saying, oh, she's just breath holding. Is that generally normal with function seizures?
Yeah, we do see quite a bit of breath holding in functional seizures, and we know that does exacerbate the seizure, which is why we do a lot of breathing work to try and regulate the breath and avoid that. So yeah, unfortunately, that is quite common.
That's where we had the oxygen level drop to at least a minimum low as 88, as low as 80 for at least a minute, at the max minute and a half. And then it came back to about the 90s, 99, 95. And then it dropped back down again. But even some that she wasn't breath holding. So that's where I'm like, yeah, where do we stand?
She said, sorry, she wasn't breath holding, or she was?
She wasn't breath holding. She's like grasping for the breath when it dropped down, like trying to get that breath, like a real deep.
Yeah. And it's really scary watching people. I work in privately in pediatric seizures and functional seizures, and even though I'm modeling being the sort of calm one, on the inside it's even quite frightening for me sometimes, just waiting for them to come out. But I know they will. But when they do that big gasp and it finishes, I'm always relieved.
Okay, let's just keep an eye on it and go from there.
Yeah, and it is scary for bystanders watching it as well as the person experiencing it. Any other questions before we wrap up? Rebecca, did you have another one?
I have support dogs now. I have 2 border collies, and they've been trained seizure response dogs. And I've found since that's been, I've had them for a year and a half. I had different border collies before, but since having them absolutely dedicated and trained to look after me, my seizures have dropped really considerably because they can let me know. So I change my activities. I have a lot of functional seizures in my sleep, so they'll actually wake me up before I have it so that I don't choke, things like that. But I'm so much better with the dogs than I was before. So much better.
Maybe we should do a study in the dogs. That'd be cool.
Well, a lot of people are finding that. I think it would be really good to do a study with assistance dogs and FND because a lot of people are having benefits with assistance dogs.
Yeah, I have a patient and her dog comes to the session and she does a similar thing. So she sort of just senses it and picks up, and then she'll sort of just all of a sudden, lie on her.
They're great.
Yeah, they hold me down if I'm in a really bad seizure. I even have cats that will lie against my head so that I'm listening to their purr instead of my gasping and the heart rate. So they really come in and they bring everything so quickly down. It's such a difference.
Yeah. Warren, did you have a question, Warren? You've got your hand up.
Yeah, I'm quite new to this. I've only been diagnosed really just recently. So I'm finding it really confusing with information on symptoms and what to look out for and things like that. So I've noticed that a lot of my symptoms keep changing sporadically and sort of go all over the place, and I'm always left going,
Warren, that's really common, and it's a bit like playing whack-a-mole. And sometimes we'll treat someone and their seizures go, but then they start collecting, or they'll sort of develop another symptom, and then we sort of treat that. It's almost like the body doesn't want to let go of it or something. It can be really tricky.
My leg will be fine, but then the seizures will just kick right in, and then the legs will start again, and then I arms and that are exhausted for 3 or 4 days. So.
And which state are you in, Warren? Do you have someone who's somewhere, a clinic or something?
I'm in between a 12-week program at the moment.
Right.
And we've gotten to a point where she's like, you've got to write down everything before you have a seizure. What were you thinking? And I'm like, it's that. And she's like, that's what you keep saying. And I'm like, that's what I've been told my whole life. It's what I've always, I don't know any better. I'm sorry. So, yeah, it's been a bit of a head cluster. I don't know.
Yeah, it's a huge roller coaster, and it does take, I can appreciate it, writing all those things down and really thinking and trying to rack your brain and think, what was different, or it does take a lot of effort, but I would say that it pays off in the end. So it's perseverance for sure. Doggedness. Yeah.
Nah, bingo.
Jasmine, you've got your hand up. Do you want to unmute Jasmine to talk? Yep. Hold on. I can't hear you. I'm not hearing you, Jasmine.
Maybe Jasmine could type her question.
Yeah, do you want to type your question, Jasmine? We're not able to hear you.
There is another, like the sleep thing. Yeah, there's another project I'm involved in. It's a sleep project, functional seizure sleep project. So, I think it's an exciting, it sounds strange to say an exciting time to have the condition, but really it's compared to say even 10 years ago, there's
absolutely.
It's amazing. If
really,
you could appreciate the amount of groups all over the world who are, really starting to do cutting edge research, and it's wonderful. So, I think.
I think the sleep study will be interesting. I see a lot of people that are really struggling with sleep and FND, and I think it's really hard to get well if your sleep is, not great.
That's right. Yeah.
Yeah. All right, have we covered everyone's questions? That's been absolutely wonderful, Lana, and thanks so much for sharing, all the work that you're doing to our members. It's really wonderful to know what's happening, the outcomes, and we look forward to hearing more about your work, so stay in contact.
Thanks, Kate. Thanks, everyone.
Thank you. Bye.
Bye.
Bye.